Today we are going to be going through some neurology SBAs. These slides were made by a doctor, so they're slightly more detailed than I would say you need to know. But we'll highlight the high yield stuff so you guys can just learn those. So we're going to go through these topics: seizures, strokes, headaches, peripheral neuropathies, movement disorders, and cranial nerve diseases. There are probably other more niche topics, but these are generally what most of the SBAs and CPSA topics will be. So I would just focus on these and then maybe know the other stuff in what is it, like surface level. Okay, I'll give you 1 minute for each question. So if you guys could have a read of this and could you unmute and say your answers, please, if that's okay? I'll let you know when 1 minute's up. Okay. Wait, can you guys still see the slides? Yeah?
No.
Oh, okay. I think I need to put this on because I want to see the Q&A as well.
Maybe we'll tell you if there's a chat.
Oh, yeah. Yeah. Can you guys do that? Okay. Okay, yeah. If you guys can let me know if there are answers in the Q&A, please.
Guys, feel free to just like shout out or put your answers in the chat, just whatever. It doesn't matter if you get stuff wrong. It just helps you more if you get involved and just guess at things.
Okay, that's 1 minute. If someone could unmute and tell us what the answer is, it will just be quicker. We can go
Someone
through.
said C.
Okay. So if that person could please unmute and tell us why they think it's C as opposed to all the other ones, how they came to that.
Yeah, sure. So because she's having a seizure, tonic-clonic seizure, and she's already got the IV access, so I think you can give lorazepam or like a benzodiazepine via IV. I think D and E are if you're like in a GP setting.
Yep.
And A and B, I was thinking I don't know about A, like, as in that's still important, but I don't know if it's actually first line or if it's not. So
yeah,
I'll put C down.
Okay, yeah. I also thought the same thing when I did this, but because this scenario is like an emergency scenario, what kind of framework do you think it would be best to use with this?
A2E.
Yeah, exactly. So which of these 5 options comes first in the A2E? Because they're all like technically correct, but one of them is before the other ones.
Then it would be A.
Oh, no, it's actually B. Yeah, so
Sure.
you want them in the correct position because that's airway, so they can actually get air in, and then B is breathing, obviously. So yes, this is just like using an A2E approach. I would say, yeah, this will always be like what they're looking for in an exam answer where they're asking for the first management step. If it's an emergency, always go through your A to E. Even if there's like a past med answer staring at you, they're looking for like an A to E kind of steps answers if they're asking for the first management. So that is quite important, I think. Yeah, so this is just a bit more about status epilepticus. It's always more than 5 minutes or 2 seizures without returning to baseline. It's an emergency, so that's why we're using A to E. Yeah, recovery position, oxygen. I don't know what MPT is, and I Googled it, and I still don't know what it is, so I wouldn't worry about it. I think it means like normal pressure and temperature, but I don't really know. Yeah, so you're right. It's IV lorazepam first line if they have IV access, and yeah, right again. If they don't have that, then it's midazolam or whatever. So one of the biggest causes of seizures is hypoglycemia. So always say glucose when you're doing your A to E, and you get to D, I think, yeah. And also think about alcoholics. Seizures, alcoholics are often caused by thiamine deficiency. So that can also be something to exclude. And then again, lorazepam can be repeated if they're still seizing after the first dose. Yeah, I guess in a real sense you would call anesthetics, but that's never like an exam answer, but on the wards, important. Okay. Yeah, so it's actually quite common. 10% have a seizure. Epilepsy is when there is recurrence of the seizures. So one seizure itself doesn't mean the patient has epilepsy. More than 2, sorry, suggestive, yeah. There's a list of causes here. I'd be aware of them, but I wouldn't memorize them. Just so you know that if a person has had one of these and they're having symptoms that are suggestive of a stroke, not of a stroke, of a seizure, then you know that they're having a seizure. But there's not really any need to learn the causes of epilepsy, I would say. But yes, this is them. So next SBA, I'll give you another minute. And if you could say the answer or type it in the chat, please. All right, that's 1 minute. If someone could unmute or put an answer in the chat, please. Or just like explain your reasoning if you don't know what the answer is. Explain how you would go about this.
I'll unmute. So I've gone for
sounds
A.
good. Uh-huh.
The main reason is he's on TEP for prosthetic cancer, I believe.
Yeah.
I wouldn't go for B because he's already on IV drip for glucose, so it's really
Yeah.
unlikely that he's going to be hypoglycemic.
Yeah.
Hypoxia, I don't know why I ruled that one out, but it doesn't, hypoxia wouldn't really present like this.
Yeah.
He's not got any neck stiffness, so it can't be meningitis. And I thought the top one, just no previous history of seizures. He's only really had one.
Yeah.
Fit, so probably not epilepsy.
Yeah, excellent. So very good reasoning. Just one thing with the meningitis, I wouldn't rule it out if there's no neck stiffness, but I would rule it out if the temperature is 37. Because I reckon it usually presents with a fever. But yeah, neck stiffness is like you would see it in an exam. So okay, this is a bit hard because it kind of takes an understanding of TERP. So there's something called TERP syndrome, which you'll learn in 5th year when you do urology, and it's quite common when someone has this procedure for their prostate because they get loaded with a load of their sodium basically drops, which causes hyponatremia. And on the other slide, it said hyponatremia is a cause of seizures. Oh, it will say in the future slide. So yes, I didn't know this at the time either, but just be aware that hyponatremia is a cause of seizures. And that is the most likely cause in this scenario. Which you're ruling out hypoglycemia because he's on the glucose. So I would say it's between those two, but then he's got glucose. So by ruling out, you would get to hyponatremia. Yeah. Does anyone have any questions with this one? Yeah, I would say this is a bit tricky if you're not aware of TERP syndrome, but yeah, if you know hyponatremia causes seizures, then that's fine. Here are some more causes. Yeah, so it will present quite commonly with vascular issues. Look for it in like subarach and things, any type of bleed, the strokes, AV malformations and vasculitis, a bit rarer, but that can happen. Yeah, so any electrolyte disturbance, but sodium is the most common electrolyte disturbance that causes seizures. So especially be aware of that. Again, glucose, hypoglycemia, uremia, temperature, oxygen. Yeah, any brain infections, so meningitis, encephalitis, the autoimmune ones. Yeah, these are a bit rarer. Also common with withdrawal and also in alcoholics and drug addicts. Yeah. And I guess you guys will come across pseudo seizures, but this is not actually due to any like electrical disturbance in the brain. This is like a, it's kind of like, yeah, you'll come across it, but it's like a functional seizure. So it's nothing's actually happening in the brain. They're just having a seizure, like physically. And the bottom line is things that can trigger seizures, usually in people with epilepsy. I don't think these will commonly cause seizures in people without epilepsy. But yeah, lack of sleep is often a trigger in epileptics. Hangover, stress, and non-adherence to their medication is a big one as well. So that's actually quite good for OSCE. In people with epilepsy, maybe presenting with a seizure, check their adherence when you're doing their drug history. Yeah, so partial and generalized are the two ways to classify seizures. Generalized is basically either a tonic-clonic, an absent seizure, an atonic, or a myoclonic. And then a partial seizure is kind of just anything else. And yeah, I got quite confused about simple and complex, but complex is just when they're not like conscious. So they lose consciousness. But simple is when they're still conscious during the seizure. Yeah, that's, yeah. So generalized is through the whole brain, partial is just one part of the brain. Yeah, and then be aware of Todd's palsy, which is just when they're really like tired after a seizure. And they might have other neurological symptoms. So that's always after a seizure. HEBS is quite a good mnemonic actually for remembering the symptoms of a focal seizure. These are quite common in SBAs. Yeah. So epigastric rising, I've seen that in so many SBAs. There'll just be like a sensation in the stomach, hallucinations, emotional disturbance. Yeah, and then, as I said, the generalized seizures is just when it affects like the entire body. So these four. So if it's not any of those four listed in generalized, it's going to be a focal seizure. So if they're just experiencing like one symptom. Important investigations. So always blood glucose, because that's a reversible cause of seizures if it's too low. So you can correct that quite easily. Observations, bloods for blood count, USNEs, LFTs. Magnesium also important because you can reverse that, and that's another electrolyte that can cause seizures if it is deranged. CT head is important to rule out any bleeds or strokes, and MRI for any space-occupying lesions like tumors. And then once referred to a specialist, they'll usually do an EEG, which will see the electrical activity in the brain and see if it is actually a seizure, and then lumbar puncture for your meningitis, all of those. And video telemetry is the gold standard because you can actually like do it during the seizure. So monitor the electrical activity during the seizure. Okay. Yeah, so this is important. You don't need to start treatment just after the first seizure. You only start it after they've had 2 seizures, because 1 seizure can be due to a reversible cause, and there's no point starting medication straight away if that is the case. So you will only start if they have 2 seizures, or they have 1 seizure with any of these features, which would indicate that they're going to have further seizures. So if they have a seizure with abnormal electrical activity, that indicates that they probably have epilepsy. So that would be a case in which you would treat them straight away. And then any other abnormality seen on imaging also indicates that they're probably likely to have further seizures. So yeah, in an SBA, if they've only had 1, but you think they're likely to have further because of any findings on investigation, then treat them straight away. Yeah. Okay, third SBA. I'll give you guys 1 minute again. Okay, that's 1 minute. If anybody would please unmute and tell us what the answer to this is, please, or just put an answer in the Q&A.
Hi again. It's B because
Okay.
lamotrigine is safe in seizures, and definitely not E because that's teratogenic.
Yeah,
So-
perfect. Yeah, very good. Yeah. Were you able to rule out any of the other ones?
Yep. So you don't want to stop lamotrigine because it's safe.
Yeah.
So not C. D. I don't think that's an anti-epileptic drug.
Okay.
So rule out D. Valproate is like really teratogenic, so not E. And you wouldn't really advise her to terminate her pregnancy because of a drug being teratogenic. So.
Yeah, perfect. Yeah, so that's correct. So lamotrigine is really, it's the safest in pregnancy. Yeah, as you said, you don't need to terminate because it is not. Yeah, you don't need to stop it either. Some drugs become, well, they become more likely to cause a defect if they're used in the 2nd trimester, but this is not one of them. So you can continue it. Phenytoin is actually used for seizures, but you wouldn't switch to that because I'm pretty sure it is teratogenic, yeah. And again, yeah, you're right. Sodium valproate is teratogenic. So good, yeah. You use lamotrigine. Yeah, so the bottom row here, lamotrigine and levetiracetam, they are both very safe in pregnancy. I'm not going to go through this, but it's a very good table to memorize. This is so high yield, I would say. Like most of the exam questions would give you the symptoms of a seizure. You've got to classify it into one of these seizure types, and then they'll ask you the treatment. So yeah, just memorize this, and also be aware of which ones can and can't be used in women and what ages. So valproate can't be used in any woman of childbearing age. So for a tonic-clonic, you would probably use lamotrigine. But in men or women of not childbearing age, you can use valproate. But yeah, memorize this. Very high yield. Side effects, again, be aware of, but don't worry too much about. So they all depress the CNS naturally because they're reducing the risk of seizures, so they'll cause drowsiness. Cerebellar toxicity, SJS is you guys probably know, Stevens-Johnson syndrome, which is like a whole body rash, and lamotrigine is the most likely to cause that, but again, very rare. Aplastic anemia, yeah, so no new cells produced. Carbamazepine. Yeah, always safety net. If you're in an OSCE, say, if you get any of these and list them, say, go to an emergency department straight away. Yeah, that will be extra marks. And then there's the whole like P450 inducers and inhibitors. Again, I wouldn't worry too much about those. Just learn it before the exam, just in case. But it takes ages, and you probably won't get a question on it. But in general, all of the anti-epileptic drugs are inducers except for valproate, which is an inhibitor. So it's easier to remember than learning all of the rules. And they all have quite unique side effects. Yeah, but you don't need to remember all the side effects of each one, because drug counseling is quite unlikely to come up in a year for OSCE station. So yeah, as I said, be aware of the side effects, but don't worry too much about memorizing them. Okay, next, SBA. Okay, if someone could tell me what the answer to this is, please. Let me know if you don't know, and I can talk through it as well. But if anyone, a guess is good as well, because you'll probably remember it if you get it wrong. So.
I just guess topiramate, but
Okay.
I don't really know what the BMI and the type 2 diabetes is relevant here for.
All right. Okay.
I'm sure it is something.
Okay. Was that literally just a guess? Like you didn't rule anything out?
So I narrowed it down to either the middle, carbamazepine, topiramate, and what's the other one? Lamotrigine.
Okay, good. Yeah, lucky guess as well. Okay, so there's several things to take into account with this. So I think the most important is the type of seizure. So generalized tonic-clonic. So you ruled out pregabalin because that's not even used for seizures. She's 60, so you kind of could assume that she's not going to be childbearing, but I wouldn't do that because they haven't explicitly said that. So I wouldn't fall into the trap of giving sodium valproate because of her age. It doesn't really matter what the cause was. That doesn't change it. The MCA infarct. What the most important thing here is the BMI. This is quite niche. I don't think. Yeah. So topiramate is the right answer, and it's because one of the side effects of it is weight loss. So although you probably would generally give lamotrigine to this patient or sodium valproate if she was not going to have any more children, in this case, you would give topiramate because of her BMI, because it would have like a double effect of, one, reducing her seizure risk, and two, also reducing her BMI. So yeah. Oh, and sodium valproate causes weight gain. I didn't even know that. Yeah, so yes, topiramate because of the weight loss. Yeah, pregabalin is not used for seizures. Yeah, good guess. Yeah, so these are the niche side effects of each one. I would probably actually learn the sodium valproate one because someone went through the trouble of making an actual mnemonic for it, so it's probably quite important. And it's quite easy to remember because the mnemonic is valproate. So yeah, memorize that. Vomiting, appetite, yeah. Valproate side effects important. Also because it's the most commonly used. So yeah, even more important. And then maybe be aware of the lamotrigine ones because that's most commonly used in women. Lots of SBAs on PassMed about phenytoin side effects, but I don't know. Yeah, it's probably not that UCL, but yeah, be aware of those two. The rest of them not really used. This one, vigabatrin, it's only used in infantile spasms. I think it's the West syndrome or the like Salam attacks, because it causes visual field defects. So yeah, that's not really used in adults. Yeah, so learn sodium valproate, be aware of lamotrigine, don't worry too much about the rest. This topiramate causing weight loss, yeah, that's a little bit QuesMed. I don't think they does that anywhere else. But yeah, be aware of all of these. Driving is quite important. Driving with epilepsy could come up in an OSCE station or even in SBA. So with these you should definitely memorize these. With a single seizure, they need to inform the DVLA. If they don't, you will have to, or you should do anyway. And then you stop driving for 6 to 12 months. Yeah, if they have epilepsy, they can't drive, so they lose their license. They can regain it if they haven't had a seizure for a whole year. If they're driving a large vehicle, it has to be 10 years. And you can get what they call an until 70 license if you haven't had a seizure for 5 years and you have epilepsy. And then there's the indications when you stop the drugs. So if you stop taking anti-epileptic drugs, then, and you also don't have a seizure for 2 years, you have, I don't even know what that means. If you stop the drug over 2 months. Yeah, I can't really make sense of that, but there's a whole PassMed bit on how to start driving again once you've stopped the drugs. While you're tapering off the medication though, you can't drive at all. And then you can't drive again until 6 months after you've tapered off. And yeah, again, the P450 system induces and inhibitors. Yeah, not too important, but they do interact with a lot of medications. So. Okay, now we're going to talk about strokes. So a stroke is a deficit for more than 24 hours, and it should be added. It should be added here, but it also has evidence on imaging, which differentiates it from a TIA, which doesn't have any evidence on imaging. So that will quite often be a question. Yeah, they'll have like stroke symptoms, but then the CT, the MRI or CT or whatever will be clear. So then it won't be a TIA, MRI. But a stroke will have evidence on imaging. And various different causes. So strokes can be both ischemic or hemorrhagic. Hemorrhagic would be like a subarach, subdural, all of those ones, extradural, and an ischemic would just be like when embolus or thrombus blocks a vessel in the brain. Yeah, can be vascular, cardiac causes, so AF often leads to that happening, and like AV malformations can also cause strokes. Okay, yeah, this is really important to know. So how to classify different strokes depending on which circulation they're affecting. So it's either going to be an anterior, posterior, or lacuna stroke in terms of where in the brain it's affecting. So for it to be an anterior stroke, you can either classify it into a total or a partial one. So in a total stroke, it has to have all three of these features. So either loss of function, motor function, or sensory function on one side of the body, so hemiparesis or hemisensory. That's number one. Number two is a homonymous hemianopia, so same side defect loss, same side visual loss in both eyes. And three is a higher cortical dysfunction. So that would be like if they can't speak, that's aphasia, and any neglect, any type of visual neglect. Those are what they call higher cortical functions. In a partial stroke, you'll only have two of those, so you won't see that loss of higher cortical function. It will only, oh no, you won't, well, you can also, yeah, so I think this second table is wrong. It's just two of the previous, two of what is seen in here. So if it's the hemiparesis or sensory deficit and the homonymous hemianopia without the higher whatever deficit, then that can also be partial. So for it to be partial, you basically only need two of the three that are in the previous, but it can be any two. Yeah, a posterior circulation defect is one affecting the cerebral arteries, so posterior inferior cerebellar artery, PICA, or yeah, any other cerebral cerebellar artery, any of the brainstem syndromes, and just homonymous hemianopia by itself with macular sparing, because that indicates that it's the posterior cerebral artery if it also has macular sparing. And then a lacuna stroke will essentially only have one symptom. So either pure motor, pure sensory, sensory motor, ataxic, or dysarthria, which is, yeah, they just can't use their hands that well. And it doesn't have any of the following. So homonymous hemianopia, drowsiness, brainstem signs, which would indicate that it's a posterior stroke, and higher cortical function lesions. So yeah, important to remember these. Yeah. So this is a big table about how to localize the specific areas of the brain that are affected depending on the symptom. I wouldn't say it's that important to know this, but I think the more aware of stroke symptoms you become, you'll kind of get a feeling of this anyway. But yeah, this won't help you too much by knowing where in the brain is affected with which symptoms. You should just know this. So which symptoms indicate that it's posterior and which symptoms indicate that it's anterior, or if it's lacuna, if it's only one symptom. Okay, if you have a go at this question, I'll give you 1 minute. Okay, could someone tell me what they think the answer to this is, please?
I was thinking B, lateral medullary syndrome.
Okay, perfect. Could you tell me why you ruled out everything else and why you picked B?
Yep. So then I was thinking about the mnemonic Danish, and that kind of fit in with the symptoms.
Yeah.
And So ruling out A, he doesn't have like a pure. He has kind of like he's presenting with loads of symptoms that are mixed.
Yep.
C is very similar to lateral medullary syndrome, but you get deafness as well. I think that's how you differentiate it.
Yeah, exactly.
And I'm not sure if D exists. I've never heard of it, but
Yeah.
just thought I'd ignore that one. And then E, you'd get more like ataxia, things like that, I guess. So
Yeah.
I'd rule that out.
Yeah, exactly. Okay, perfect. Thank you.
Not Danish, it's Danva.
Yeah, well, I think Danish also works, but this PowerPoint's a bit old. They probably added some new ones. Yes, you're exactly right. So way too many symptoms for lacuna, got loads of Danvos symptoms. Pontine needs the hearing loss. I've never heard of medial either, but I don't know. And yeah, correct. So he hasn't got the ataxia and stuff. Okay, so this is the Danva mnemonic. I would learn this or Danish. Yeah. So, and they've also linked it to every nucleus that's affected. Again, I wouldn't worry too much about the nuclei, just learn the different symptoms of a lateral medullary stroke. So, yeah, pica is the posterior inferior cerebellar artery. So this would be classed as a posterior circulation stroke because it's a cerebellar one. The Danva mnemonic is here, very important. Yeah. Yeah, just learned that. Okay, next one. I'm going to give you guys 30 seconds just because we don't want to run over. So, yeah. Okay, could someone unmute and tell us what this one is, please?
Is it B, Weber's syndrome?
Yeah, perfect. If you just tell me why you picked Weber's, we don't need to rule out any others.
So I remember as there's a web in my eye. So he's got a down and out position.
Yeah, exactly. Perfect. And I used to get quite confused between this and Wallenberg's because that also presents with Horner's, which is the last one in the Danva mnemonic. But down and out position of the eyeball and dilation is a third nerve palsy, which is different to Horner's because Horner's has constriction and ptosis and anhidrosis. Yeah. So yeah, know the difference between third nerve palsy and Horner's because they're not the same. Yeah, perfect. Yep, as you said, good way to remember is there's a web in my eye. So Weber's affects third nerve. And it's always ipsilateral as well. So same eye is affected on the same side. Yeah, it's an anterior midbrain infarct. And again, it's a posterior stroke. Yeah. But the opposite side of the body and the face will be affected. But the same side has the eye symptoms. Okay, next SBA. I'll give you guys 30 seconds again. Okay, could someone tell us what this one is, please?
I'll go again. Yeah, I went with D.
Oh, sorry. Okay, perfect. Yeah. Correct. Aspirin. I'll rule out the other ones. So you can't do thrombolysis because it's been 12 hours. And if you look at the symptoms in this, you guys will probably have worked out it's an anterior circulation infarct. So that in that case, I'll go through it in the next slide, but you have a 4.5-hour window to do your thrombolysis. So 12 hours is too long to still do that. Warfarin, no scans have been done, so he could very well be having a hemorrhagic stroke. Warfarin will only make that worse, so you can't do that yet. Oh wait, CT has been done. Still, you can't give warfarin for a CT if it's showing an ischemic stroke. Low molecular weight heparin, that's used for the venous kind of strokes, not one of these. And clopidogrel, you'll start after 2 weeks. So yeah, aspirin should be given straight away as soon as you think they're having a stroke. Yeah, warfarin. So you don't want to transform this stroke into hemorrhagic stroke. Okay. Next one, I'll give you another 30 seconds. All right. Does anyone know what this one would be? Are you guys struggling with this one or just shy? No? Yeah, any thoughts? Again, good to get it wrong because you'll probably remember it. No? Okay. So this one is urgent CT head. Here, from all these symptoms, you don't know what they're having. So before you start treating anything, you need to rule out that they're having a bleed, which you don't want to make worse. So you're going to do an urgent CT head. All of his background is kind of indicative of cardiovascular risk factors. So you're already thinking stroke. Then on top of that, he's got kind of stroke symptoms. He's got the nystagmus, difficulty standing. That's pointing to a neurological cause. So with this, we're thinking stroke, but we don't know what's causing the stroke. So you don't know yet if it's ischemic or if it's hemorrhagic. So before treating any kind of stroke, we want to rule out that it's hemorrhagic. So first step is an urgent CT head. Prochlorperazine is used for vertigo usually, but this is seeming a bit more sinister because it's got the sudden onset. So I wouldn't assume that it's sudden. He's suddenly developed vertigo and difficulty standing on top of these risk factors. Again, thrombolysis you can't give without ruling out the bleed. Aspirin, again, will make him bleed more. And epi maneuver, oh, nah, he hasn't got the turning the head, dizziness, and all of that. So I'm not even thinking BPPV. Okay, yeah, so CT head for this. Stroke management. So yeah, this comes up a lot. Again, always image to rule out a bleed. MRI is more useful for a TIA. But because he's had symptoms for a while, we would pick CT head. Less suspicious of TIA. ABCD always because it's an emergency. ECG because you're looking for AF, which could be another risk factor for stroke. Glucose, bloods are important because hematological things can be predispose them to hemorrhagic stroke. And then imaging it's very urgent, so you want to do it within an hour. Okay, the timelines I would memorize carefully, and this doesn't have it in the full detail that PassMed does, but the timings are also different for anterior and posterior circulation strokes. So I would go and look at that and learn it because that's important. So if it's an anterior circulation infarct and it's within 4.5 hours, you give them thrombolysis straight away, which is IV alteplase. And then if it's within 6 hours, they can also have a thrombectomy. I would check this on PassMed because, as I said, it's different for posterior. And then it's also different if they have what they call like salvageable tissue on imaging, which gives them a greater window for thrombectomy. So yeah, so what they're kind of implying is that if there's more tissue that can be saved on imaging, then you have more time to do your thrombectomy. But that's not included here. So I would go and read that. But yes, very important. And then if it's a hemorrhagic stroke, just neurosurgery straight away and reduce the blood pressure, which will reduce the bleeding. And your A to E is given here on the right. Yeah, all kind of same thing. So yeah, most important things are the CT head ASAP to rule out bleed, and then the timings for the thrombolysis and the thrombectomy, which I would look on PassMed for more detail. Yeah, so subsequently in practice, you would want to look at what caused them to have the strokes. You do all these tests, Holter for AF, echo for any cardiac defects, carotid Dopplers to see if it's like a blockage there. But that would be more of a TIA management because then they do the endarterectomy to reduce the risk of a stroke happening. And then in the long term, after your 2 weeks of having aspirin 300 milligrams, you then start them on clopidogrel, or the second line is aspirin and this one, which you do for their whole life. Or if they have AF, then you give them warfarin or a DOAC to prevent the clot forming. So yeah, that's stroke management. Important to know this clopidogrel after 2 weeks thing. And statins to reduce their cardiovascular risk factors. Okay, that's all of that. Let me stop sharing. Okay.
Okay, I'll try and there we go. Can you guys see that? Can you see the slides?
Yeah.
No. Yeah, now I can.
Okay. Does it go
Wait,
off
no.
when I click?
No, wait, I can't see them. Okay, I can see them now.
Okay.
Yeah.
Okay, cool. Okay, so I'll do part 2. So we'll start with SBA 9. A 72-year-old woman with a history of treated hypertension presents for review. Yesterday, she had a 2-hour episode where she couldn't find the right words when speaking. These symptoms have now fully resolved. This has never happened before, and there were no associated features. Neurological examination is unremarkable, and blood pressure was 150/100, and her only current medication is amlodipine. So before we do the question, what's the most appropriate management? What condition does everyone think she's had? Feel free to shout out or put in the chat. Or in the Q&A bit.
TIA.
So she's had, yes, TIA. Very good. So in terms of risk factors for TIA, she's 72, which is quite, age over 55 is quite a big risk factor for TIA. There's also specific ethnicities which increase your risk of a TIA. And then there's all the classic stuff. So there's diabetes, weight and diet, smoking and alcohol. So yeah, the question is, what's the most appropriate management for the TIA that she's had? So yeah, feel free to shout out, put in the chat. Have a guess if you're not sure.
Was it C?
C, okay. What's your reasoning for C?
Because I don't know, I just remember it as one of the guidelines. Could be wrong.
Okay. Does anyone agree, disagree? Let's see. Any other thoughts? I'll give you guys like 10 more seconds and then we'll go. through it.
I thought it was either A or C, but I don't know why you'd wait a whole 2 weeks. That's why I went for C.
Okay, so the correct answer is C. We'll go through the guidelines, but yeah, basically for most of stroke and TIA management, it's just what the guidelines are. And it's just really good to learn these because they come up, as Surani said, lots. Like you can probably have 2 or 3 questions on stroke at least in your exams. So basically in terms of this, it's mostly guidelines, but you do the specialist review within 24 hours because she had the TIA. You wouldn't really do 2 weeks. I don't think at any point of TIA management you do 2 weeks. There is one case in which you do 1 week, which we'll go through in a second. One of the options, option D, was for a head CT, but there's no need for head CT because the TIA was fully reversed. And also there's no bleeding disorders that she has a history of. So there's no real suspicion for a bleeding, a hemorrhagic cause for the TIA. So there's no need. And also it's aspirin 300 milligrams. Does anyone know when you'd give 75 milligrams instead? Or just in general when you'd give 75 milligrams of aspirin?
The secondary management.
Yeah, good. So for secondary management, for prevention of strokes and complications like that, that's 75 milligrams instead of 300. And 300 is always for acute complications. So you don't usually continue patients on that for lifetime. So in terms of a TIA is a sudden onset vascular neurological deficit lasting less than 24 hours. Normally in most questions on past med and exams, they'll say that it resolves within an hour just to make it more obvious it's a TIA, but it doesn't have to. It has to just finish within 24 hours, which in real life can be confusing, but I think in exams they won't have it 24 hours because then you might think it's a stroke. When someone's suspected of a TIA, one of the first things they'll do is check glucose because it's a reversible cause of a TIA. And there's also an ABCD2 score, which you guys might have heard of. It can be useful to be aware of, but I wouldn't say there's any point learning it. I'll show you guys in a second, but I'd say just be aware of it. In terms of investigations for stroke, for TIA, it's the same as stroke because you're basically ruling out a stroke. So it's the exact same thing. And there's also a thing called crescendo TIA, which is basically when you have multiple TIAs over days or hours, but it basically has the same management as a normal TIA. So this is the ABCD2 score. So you get points, as you can see, for age, blood pressure, the features of TIA, duration of symptoms, and any history of diabetes. And based upon the score, it predicts your risk of having a stroke within the next 2 days. So in terms of this score, it's like kind of clinically debated whether it's actually useful or not. Like it's not really used to guide management for patients, but it's good to be aware of it. Like according to NICE, it's good to be aware of it, but it shouldn't be used in management. So yeah, I think mostly just know the name of the score and the different components of it, but I wouldn't bother learning how many points you give for each factor. I don't think that's likely to come up at all. Okay, so in terms of the management of TIA, it depends whether the TIA was within the 7 days or over 7 days ago. So if the patient presents within 7 days, you want to start aspirin 300 milligrams immediately, like we said, without need for a CT. And if the patient is already on low-dose aspirin, then continue them on low-dose. There's no need to change them up to 300. And then they should also be seen by a specialist within 24 hours. And if they have bleeding disorders or they're on anticoagulants, then you need to CT them. But otherwise, in a TIA, you don't need to CT them to exclude hemorrhage. And if the patient presents thinking they've had a TIA over 7 days ago, you want to refer them for urgent assessment within 7 days. So just think of it as like TIA 7 days, over 7 days ago, refer for urgent assessment within 7 days. And in terms of this, you mainly just have to know that they shouldn't drive until specialist assessment. But there are specifics. I don't know how likely this is to come up. They're more likely to ask you about driving after a stroke than driving after a TIA. But just in case, if they've had a single TIA, they're not technically supposed to drive for a month, but they don't have to tell the DVLA. And if they've had multiple TIAs, then they mustn't drive for 3 months, and they are supposed to notify the DVLA. But once again, I don't know if they'd actually examine you on that. It's a little bit niche. I'd say learn stroke and maybe just be aware of DVLA things for TIA. And yeah, at the bottom, you can just see the different managements for resolved TIA symptoms, before specialist review, after specialist review, and long-term prevention. So you start with aspirin high dose, then you switch to low dose aspirin, low dose clopidogrel, and then you long-term give them clopidogrel. Okay, so just going on to SBA 10. If anyone has any questions, by the way, feel free to ask. But SBA 10, an 80-year-old man presents to ED with a short history of increasing confusion and feeling dazed. He mentions having fallen in his bathroom 3 weeks ago, after which he was examined by his GP, who reported a normal physical examination. The patient has a history of hypertension, for which he takes benzoflumethiazide. He's currently afebrile with a regular pulse of 80 and blood pressure of 152/86. His GCS is 15, but his responses to questions are slightly slow. He seems disorientated to time, and there's also some deficit in recent memory. So neurological examination shows slight hyperactivity of tendon reflexes on the right side, and his plantar responses are unclear. So which of the following would be the most appropriate next investigation for this man? I'll just give you guys a bit of time to think, and then feel free to shout out or type the answer in the Q&A bit. Okay, does anyone want to shout out? Or feel free to put the answer in the chat if you don't want to speak.
Is it B?
B, okay. What's your reasoning behind B?
Because he's fallen, he may have like hit his head, so you'd want to rule out any intracranial bleeds.
Okay. Okay, and what would you be suspecting in this guy? What's your most likely differential? Like what kind of bleed?
Because of like lucid intervals, maybe extradural.
Okay.
Sure.
So you're right, the answer is B. You'd want to do CT of the head. It's actually subdural. We can go through why. Basically, in people who are older, so 80-year-old man, you'd suspect subdural, whereas in people who are younger, usually playing some sort of sport or doing something like extreme sports, such as motorbiking or something like that, where you can get a really high impact injury, that's when you suspect extradural. So usually for a subdural hematoma hemorrhage, you'll see a history of someone who's quite old, who's just had a very small fall or a really small injury, and they've got symptoms of a bleed, such as this guy. In terms of the other answers, for the 24-hour ambulatory ECG, you do that when you're suspecting paroxysmal arrhythmia. In terms of doing Dopplers of the carotid arteries, you would do this if you're suspecting carotid stenosis leading to stroke. EMG you would do for muscle or PNS disease, so peripheral nervous system disease, and serum alcohol concentration just if they have symptoms of intoxication, which wasn't really relevant, I guess, in this one. Yeah, but you can tell from the symptoms that he has. So, for example, he has hyperactivity of his tendon reflexes. That would typically show. Does anyone know if that's upper or lower motor neuron symptom? So that's usually an upper motor neuron symptom. So if you have hyperactivity, hyperreflexia, and that kind of indicates that there's a bleed in the head. Okay, so moving on to SBA 11. A 34-year-old female presents with vomiting preceded by an occipital headache of less than an hour onset. On examination, she's conscious and alert with photophobia, but no neck stiffness. CT brain without contrast shows no abnormalities. What do you think is the most appropriate next investigation? So once again, what would be your top differential for this? And what condition do you guys think each investigation will be looking for? I'll just give you guys a bit of time to think. Okay, does anyone want to shout out what they think?
Is this one C? CSF exam.
Okay, what's your reasoning behind choosing C?
I think she's got a subarachnoid hemorrhage.
Okay.
Because of the occipital headache that came on quite quickly, with some signs of like photophobia. And it won't, I don't think it shows up immediately on the CT, but then if you do a lumbar puncture after a while, you might get the color change. I forgot what it's called. But yeah, on the lumbar puncture.
Yeah, that's perfect. That's exactly right. Do you know what some of the other investigations would be looking for? So if you did D, for example, cerebral angiography, what would that be looking for?
Is that for the, what's it called? Sinus something? Sinus thrombosis or central? I don't know. I can't remember the name.
That's okay. It's a hard question. But yeah, you're right. So you would do CSF examination 12 hours after the onset of the headache, and you're looking for xanthochromia, which is the thing that you said. So xanthochromia is basically when the blood that leaks into the CSF gets broken down, and therefore you have the yellowness from bilirubin. I think it's from bilirubin, I'm pretty sure. And usually you need to wait 12 hours from the time that the patient started having symptoms, so from the thunderclap headache, for the blood to be broken down to see that sign. So in terms of the others, you can see D, that's if you suspect a berry aneurysm. So in a patient who might have like, I think it's polycystic kidney disease that you have berry aneurysms with, in that kind of patient, you might want to do cerebral angiography. Do you guys know the difference between when you would want to do CT brain with contrast and when you'd want to do it without contrast? It's fine if you don't, I can just go through it if you're not sure. But just shout out if you know.
Maybe like difference between venous and arterial problems.
Okay, that's a good guess. Basically, I think the way I usually remember it is you want to use contrast. So like in this question, you want to use contrast if you're looking for something specific. So if you're looking for something like a tumor or some sort of infection, basically any mass that isn't blood, then you'd want to do contrast. But if you're looking for just bleeding in general, then you don't want to do contrast, because in the CT, blood will usually appear quite bright white, so it'll be hyperdense. And if you give contrast, that's also going to be hyperdense. So it's kind of going to cover up the blood if you give contrast. So you don't want to give contrast if you're looking for an acute hemorrhage, but you want to give it if you're looking for tumors, if you're looking for toxoplasmosis, like the ring enhancing lesion, in those kinds of situations. Yep. So in terms of diagnosing a subarachnoid hemorrhage, these are just the criteria from the NICE website on how to diagnose it. So if the CT head scan that you do within 6 hours of symptoms doesn't show evidence of a subarachnoid hemorrhage, it does say do not routinely offer a lumbar puncture. But in practice, usually I think I don't know in practice, but in past meds and in exams, usually you do, just to investigate further. You don't do it within 6 hours, you do it within 12, but you usually do consider a lumbar puncture. But I guess in practice, you would talk to your specialist and you'd get their advice. If the CT scan was done more than 6 hours after symptom onset, that usually reduces its sensitivity to subarachnoid hemorrhage or just hemorrhage in general. So you'd be more likely to consider a lumbar puncture in practice than you would have been if that CT scan was done less than 6 hours ago, within 6 hours of symptom onset. Because within 6 hours of symptom onset, the CT scan is a lot more sensitive than after 6 hours, because the blood starts to be broken down into fluid over time. And yeah, these are just the general guidelines for lumbar puncture during subarachnoid hemorrhage. If you... Oh, no, that's fine. Okay. So if you suspect that the subarachnoid hemorrhage was due to an aneurysm, this is what you do. So this is in the case of like a berry aneurysm, for example. So you'd want to, first of all, have supportive management, as part of which you'd want to give VTE prophylaxis, and you'd also want to discontinue any antithrombotics they might be on previously and reverse any anticoagulation. So you might want to give like vitamin K, prothrombin complex, all of that stuff. then because it's bleeding, to prevent vasospasm, you'd want to give nimodipine, and I think that reduces the neural excitation. I'm not 100% sure on that, but I think that's how that works. And then usually to treat the aneurysm, if it needs to be treated, it doesn't always, but if it does, usually what you do is a coil by interventional neuroradiologists. This doesn't come up that often, but this could be a question. So usually the answer would be a coil by an interventional radiologist. In some cases, some rare cases, I don't really know the indication. I don't think we have to know. In some rare cases, you can do a craniotomy and clipping, but that's very, very invasive. So you wouldn't normally do that. But yeah, just remember from this slide, just remember the stuff in bold. Okay, so we can give you a 5-minute break if you guys want to just grab a drink, grab some biscuits, just because it's been kind of long. And then we can come back. And if you guys could just fill out the feedback. We'll also have this at the end if you want to do it at the end instead. So yeah, if you guys want to come back for maybe 7:19, maybe. Okay, guys, let's get started again. I think the QR code might have been wrong from the first time around. So if you haven't filled it out already, if you could just fill out the new one. We'll also have the new one at the end as well, if you want to just fill out them. It just helps us know like what things to change, what things to do the same. But let's get going. So moving on to SBA 12. A 12-year-old boy is brought into ED. He was hit on the side of his head by a cricket ball. His teacher describes him initially collapsing to the ground and complaining of a sore head. After 2 minutes, he got up, said he felt okay, and continued playing. And then after 30 minutes, he suddenly collapsed to the ground and lost consciousness. What type of injury is he most likely to have sustained? And those are the options. I'm not sure if everyone knows what a cerebral contusion is. I wasn't quite sure. But basically, cerebral contusions and hematomas, they're both from local trauma to the occipital area. It's just like a small bleed sort of thing. It can be anywhere. But yeah, I'll give you guys a few seconds to think about it, and then feel free to shout up. Okay, does anyone want to shout out what they think the answer might be?
Is it D?
D. Okay, based off what? What would your reasoning be?
Lucid interval.
Yep, that's correct. That's absolutely right. So this is like a very typical presentation of an extradural hematoma. So someone gets injured to the side of the head, and that's like specifically the pterion bone, which is like around here. They usually collapse and they get up and they feel okay for like half an hour. It can be up to like 2 hours, and then suddenly they'll collapse again. And usually with an extradural hematoma or hemorrhage, you'll see it in someone who's younger. So it's not, because it's usually caused by trauma. It can be extensive. It can just be something like this, as long as it's to the side of the head. So usually with extradural, the patient will be younger. With subdural, they'll be older. Yeah, which you can see E is subdural. You'd have the elderly, you'd have confusion. Subarachnoid, you'd have thunderclap, headache. It can be spontaneous. And cerebral contusion is just a bleed. I don't think you really need to learn about contusion. I think that's a bit random. So these are the differentiating factors between the three main types of bleeds that you're going to get assessed on, probably, I think. Subdural, extradural, and subarachnoid. I've kind of put the main points in bold. So with extradural, it's always trauma. Well, it's almost always trauma. And that's usually because it's rupture or damage to the middle meningeal artery, which runs quite superficial on the pterion bone. With subdural, it's damage to the bridging veins in the elderly, and these can get damaged quite easily in the elderly. And with subarachnoid, it's spontaneous. With subdural, usually it's the elderly. They'll present with a slow onset decline in memory. They'll be confused. With extradural, it's a lot more sudden. And then you can kind of see in the CTs here, and I'll also show you the next slide. Those are how those different bleeds look. So with epidural / extradural, you can see it's kind of a bit lemon-shaped, whereas subdural is more crescenteric. It's really good to go through these images on Radiopedia and just on Google and just get super familiar with them, because it's so easy for them to be examined. And I think they do get examined decently often. You could even get them as part of an OSCE station and have to explain it or interpret it. So definitely be aware. In terms of the things that appear hyperdense, so as I mentioned earlier, blood is usually hyperdense, so it's white. Also calcification. And if you've given any contrast on a CT, that's going to appear as white. And the things that usually appear darker are air, CSF, fat, and hematomas. So if it's an elderly patient who sort of had a fall about 2 weeks ago and they've been getting more and more confused ever since then, when you do a CT, you're not going to see this bright, characteristic crescenteric shape, you might see something quite dull and quite dark, and that's because it's a hematoma and the blood has actually already been broken down, and that's why it doesn't appear white anymore. So in this slide, you can kind of see what the typical bleeding patterns are like. So you can see in the epidural or extradural hematoma that it's not limited by the suture lines. So it kind of takes on this lemon shape, whereas the subdural becomes a more crescenteric shape because it's limited by the suture lines on one side and the brain parenchyma on the other side. In terms of an intracerebral hemorrhage, this can kind of happen anywhere. You don't really get examined on that as much. And the subarachnoid hemorrhage is just within the cisterns in the brain. Let me know if you guys have any questions. Just feel free to shout out. And the presentation for all of these bleeds will be a headache, which can be chronic, it can be very severe, it can be very dull. There's like millions of causes of headache, so it's really important to take like a specific headache history based off what you suspect is going on. And primary causes of headaches include migraines with or without aura, tension headaches, or things such as trigeminal neuralgia. If you had a young woman coming in with a migraine with, say, like a visual aura, what would you want to check in terms of her medications? Does anyone know?
She's on the oral contraceptive pill.
Yeah, perfect. And why?
Is it like it worsens migraines, or is it like a contraindication?
Yeah, so it's an absolute contraindication. Being on the oral contraceptive pill is a really high risk for stroke in somebody who has migraines with aura. But it's fine if it's without aura, but you'd still want them to tell you just in case that migraine progresses and start having them with aura instead. But yeah, that's one of the few absolute contraindications. So in terms of secondary causes of headache, you can have lots. You can have vascular causes, such as stroke, bleeds, infectious causes, such as meningitis, surgical causes, such as tumors, metabolic, drugs, anatomical. Yeah, definitely worth spending a lot of time understanding headaches and the different causes and how they present. This table kind of goes through a lot of conditions. I would say probably learn all the conditions that this table has, apart from maybe methanol toxicity. I'm not sure how relevant that is, how likely that is to come up, but everything else definitely learn. I wouldn't say this table is the best way to learn them, but all of these conditions are definitely examinable. Okay, so moving on to SBA 13. A 25-year-old man presents for review. For the past year, he's been experiencing headaches, and these are now occurring 5 to 6 times per month and typically last all day when they occur. They're not associated with any form of aura. He describes them as a severe throbbing on both sides of his head associated with nausea and lethargy. When he gets such a headache, he typically goes to bed so he can sleep it off. Before going to bed, he usually takes one of his father's diclofenac tablets, which seems to help. His neurological examination is unremarkable. What's the most likely diagnosis? Usually with UCL questions, they won't be this detailed. I think because these were written by a doctor, they give you a lot more information than UCL would typically give you. So definitely just keep that in mind with these. UCL tend to be a little bit more. They'll give you 2-3 lines, 2-3 symptoms, and then expect you to go for it. But yeah, this is a decently straightforward one. So I'll give you guys sort of 10-15 seconds, and then feel free to shout out. Okay, does anyone want to have a guess? Don't worry if you get it wrong. It doesn't matter. You'll learn it a lot better if you get it wrong, and you'll understand it better. Anyone want to have a stab?
Tension headache.
Tension headache. That's a really good differential. This one's actually a migraine, but I think I can see why you'd say tension headache because it's bilateral, I'm guessing. So
Yeah.
it's important, just bear in mind that like they might sometimes try to throw you off with having like a sort of non-typical presentation. So yeah, usually with migraines, you will have one-sided. They're never normally described as bilateral. But yeah, for that reason, I think tension would be definitely a really good differential because they are usually bilateral. They feel like a band around the head. I think maybe in this one, just because it has more symptoms of migraine, such as throbbing on both sides of his head, also the diclofenac helping and needing to go to bed to sleep it off. So usually with someone with migraine, they'll always need to sort of go rest, go to a dark area to get rid of it. They can't ever continue doing what they're doing. I think that might be why maybe it's slightly closer to migraine. But I think tension would definitely be a good sort of second choice for this one. Let's talk about the others. Does anyone know the management or prophylaxis for cluster headaches?
Is it verapamil?
Yep. Anything else that you'd give? For the acute management of cluster headaches, verapamil is the prophylaxis, yeah.
Oxygen?
Yeah. Good. So you'd give 100% oxygen and you'd give subcutaneous triptans. And then for prophylaxis, you'd give verapamil. Okay. And just with raised intracranial pressure headaches, just keep in mind that anything that increases the pressure inside the body, so such as coughing, sneezing, any sorts of that kind of movement, they will cause an increase in pain in a raised intracranial pressure headache. Also, if they lean forwards or if they bend over, that will cause a lot of pain. So these are the diagnostic criteria for migraine without aura. I wouldn't bother learning them as diagnostic criteria, but the symptoms that I described here are definitely very specific to migraines without aura. So definitely know the symptoms, but I don't think there's any need to learn all the different specific numerical criteria. There's no point of that. But yeah, basically, usually severe, usually almost always unilateral. I haven't actually heard of the bilateral one, but that question. Throbbing, like a throbbing, pulsating pain, worsened by any sort of activity, and they'll usually have nausea, vomiting, which in some people relieves the migraine, and they'll be very sensitive to light, sound, smell, anything like that. Okay, so I'm just going to speed along a little bit just because we're slowly running out of time. So SBA 14, a 69-year-old woman presents with a 3-week history of a headache which is worse on the right side. She's generally unwell and she feels quite weak, noting particular difficulty when she tries to get up from a chair. Her ESR is markedly raised. What's the best treatment? What do you guys think the likely diagnosis is for this lady?
Like polymyalgia rheumatica and GCA?
Yeah, that's literally perfect. Yeah. So those are the two conditions which cause the most characteristic symptom of needing help or difficulty in getting up from a chair, like that shoulder girdle weakness, the hip girdle weakness. Do you guys want to have a go at what the best treatment for this patient is, based off which one of those two you think is the most likely differential for her?
Oral prednisolone.
Yeah, perfect. Do you know what the purpose of the prednisolone is for this, and which condition are you saying that it is?
GCA.
Yeah.
Is it stopped the visual loss? Or
Yeah, perfect. And in GCA, if the patient comes in and they've already got some visual loss, do you know what you would give in that case?
then it goes to intravenous methylprednisolone.
Yeah, perfect. So if the patient comes in, they already have some visual loss, then it's always methylprednisolone. And if they don't have any visual loss yet, but you want to prevent it, you want to give oral prednisolone. And yeah, this one is GCA. And the symptoms, in terms of the rheumatic symptoms, are definitely most comparable to polymyalgia rheumatica. So that's one of the good ways of remembering it. Also in GCA, the visual loss is almost always completely irreversible. So when you're giving these steroids, you're not really giving them for the eye that's already got visual loss. You're giving them to hopefully prevent the other eye from developing any symptoms. So in terms of, because I said GCA and PMR can be quite similar, in terms of differentiating the musculoskeletal symptoms from PMR in GCA, the polymyalgia rheumatica symptoms are usually more proximal muscle stiffness, whereas GCA is typically more weakness. So that's a good way to kind of differentiate if you see a patient who doesn't have as many of the visual symptoms and you're not 100% sure. Also, in terms of the actual investigations, in polymyalgia rheumatica, the creatinine kinase and the EMG are normal, whereas in GCA, obviously, you'll see a raise in creatinine kinase. And this is a table which kind of goes through some of the key differences, but they are quite similar. Okay, so this is a table on specific treatments for different headaches. I think this is definitely very, very high yield. Maybe screenshot this, or I think you're probably being sent the slides after. I'm not 100% sure. But this is definitely very good knowledge to learn. This will come up lots and lots and lots. Yeah, I'd recommend learning this. So let's talk about Parkinson's syndrome a little bit. So the key difference between the syndrome and the disease is just that in a lot of different conditions, you can have the three main symptoms of Parkinson, the three kind of classic Parkinsonian triad, without having the actual, I think it's the tau and amyloid deposits. You can still have the symptoms, and that's Parkinson's syndrome. So that's the bradykinesia, rigidity, and tremor. Does anyone know what specific type of rigidity or what specific tremor you have?
Cogwheel rigidity.
Yeah, good. And what kind of tremor?
Hill rolling.
Yeah, good. That's perfect. So one of the so in psychosis, because you have higher levels of dopamine and you can give antipsychotics to block dopamine, these antipsychotics can then actually cause Parkinson's syndrome because they're blocking the dopamine. So that's just an important thing to be aware of. So you might see a patient who's on haloperidol or chlorpromazine, or they might be described as having a diagnosis of psychosis, and they might come in with the Parkinson's triad. So then that would be, make sure to keep in mind that would be Parkinson's syndrome, not Parkinson's disease. And that is a question that could come up, differentiating between the two. So these are different causes of Parkinson's. As we said, different antipsychotics. You can have idiopathic Parkinson's disease, but then that would be disease, not syndrome. You can have all the Parkinson plus syndromes, which we'll go through in a sec. There's hereditary causes such as Wilson's, which I don't think I knew, and you can also have trauma. So SBA 15, a 72-year-old female presents with progressive immobility, poor balance, and tremor. On examination, you notice a left-sided resting tremor, non-velocity dependent hypertonia of all four limbs, and bradykinesia, as well as dysarthria. On examination of the cranial nerves, you notice that she has difficulties moving her eyes in the vertical plane. What's the most likely diagnosis? This one's a little bit hard. I always found this quite tricky, but feel free to have a guess. It's completely fine if you're wrong. And I think with the Parkinson's plus syndromes, they can be kind of tricky to learn, but they definitely do come up. I think I don't remember, but I think we probably got a question last year on one of these. So it is worth spending a little bit of time just finding a way to differentiate between them. But yeah, I'll give you guys like another 10 seconds. And then if someone could shout out. Okay, does anyone want to have a go? This is quite a hard one.
Is it B?
B. Okay, so progressive supranuclear palsy. Okay, what's your reasoning behind this one? Or was it a guess?
I was thinking the poor balance. So progressive supranuclear palsy, you get falls, and the inability of moving our eyes in vertical plane.
Yeah, perfect. So yeah, that's pretty much exactly it. Especially the gaze palsies, that's like a very classic symptom of progressive supranuclear palsy. In the others, in multi-system atrophy, I think I have a slide on this in a sec. But just for generally, multi-system atrophy, I find that questions especially have a lot of mentions of changes in blood pressure. So that's something that's quite typical of that. So if we look at this, multiple system atrophy, you can have early autonomic dysfunction. You can have any of the cerebellar signs. So that's any of the Danish signs, dysdiadokinesia, ataxia, etc. Progressive supranuclear palsy, so you have loss of the vertical conjugate gaze, and yeah, you have lots of falls. You have early postural instability. It can be kind of confusing because multiple system atrophy has the blood pressure, whereas progressive supranuclear palsy has the postural instability, and it can be easy to kind of confuse the two and think that the instability is because of blood pressure. So just be careful to not fall into that trap. And then Lewy body dementia. The way I would just remember Lewy body dementia is visual hallucinations, REM sleep disturbance, and fluctuations in consciousness. I think especially in questions, they like to put in the visual hallucinations. So just be aware of that. And corticobasal degeneration, you can have alien limb phenomenon. In terms of the MRI signs, the hot cross bun sign and the hummingbird sign, I think it's really unlikely that they'd actually give you an MRI to interpret with one of those signs. They could do, so maybe just take a look at a few photos, but I think it's very unlikely. They might ask you a question where the sign is described. I don't know how likely that is. I think it's more likely they just describe the symptoms of a Parkinson's plus syndrome to you and ask you to explain which one it is. Okay, SBA 16. A 65-year-old man is referred to the neurology outpatient clinic due to arresting tremor of his right hand. A diagnosis of Parkinson's disease is made. He's otherwise well, and he's not currently disabled by his symptoms. What's the most appropriate treatment? I'll give you guys like 15 seconds, 15, 20 seconds. Okay, does anyone want to shout out?
Is it B?
Good. And why is it B?
Because you want to delay Parkinson's drugs for as long as possible until they start experiencing really bad symptoms, and he is otherwise well and is not currently disabled by his symptoms, so you don't want to do anything right now.
Yeah, perfect. And why is it that you want to delay Parkinson's drugs until the last possible?
A lot of side effect, like on motor functioning or something, yeah.
Mm-hmm. Yeah, that's correct. So with Parkinson's treatment, you can either give dopamine or you can give dopamine agonist, sorry. So usually the actual dopamine agents, so levodopa, you want to delay that for as long as possible because, as has been said, the side effects are pretty bad, but also because the longer you give levodopa for, the less effective it gets. Because in Parkinson's, you start to develop symptoms that can no longer be treated by levodopa. So if you start a patient quite early on, then levodopa is no longer going to be effective for them later on, and you're going to have to find something else. And levodopa is the most effective drug, I think, for treating Parkinson's. So yeah, you only really want to give it if the patient states that their daily activities are quite significantly affected by Parkinson's. Otherwise, you might want to, in younger patients, you might want to give dopamine agonists, such as bromocriptine and cabergoline. These are less effective, but they also have less side effects. So that's why they're typically used in people who are younger. And if you are giving levodopa to someone who's a little bit older, then you want to give it with a decarboxylase inhibitor, so carbidopa. And just make sure you remember that levodopa is the dopamine replacement, and carbidopa is the decarboxylase inhibitor, which stops it from being metabolized outside the brain. Because if it was metabolized outside the brain in large quantities, it would cause lots of GI side effects. Just be really uncomfortable. It could cause hypotension, arrhythmias. Those kinds of things are pretty regularly tested. So definitely be aware of levodopa with the carbidopa and the reasoning for every single drug. And definitely the fact that levodopa decreases in efficiency over time, that's pretty well tested. So definitely be aware of that too. So yeah, common adverse effects of levodopa: dry mouth, postural hypotension, which as you can imagine is pretty troublesome in older people. It can cause dopamine disorders, so like psychosis, and it can cause anorexia, palpitations. The palpitations are because even if you give carbidopa with the levodopa, you're still going to have a little bit of peripheral metabolization. So you're still going to have a little bit of cardiac side effects. End of dose wearing off is a little bit of a problem with levodopa, because the patient's symptoms aren't adequately controlled the entire time. It just depends when the dose is given. So towards the end of the day, the symptoms will come back a little bit. Also, the on and off phenomenon. So when they haven't taken the medication yet, the symptoms are going to be bad. So the patients can't be super stable all the time. It's also really important to never acutely stop levodopa. And this is also something that could come up in the question really easily. A patient who's normally on levodopa has been admitted, and it might be something like you need to prescribe their regular medications, or like you just need to take a look at their prescriptions and something's wrong, what's wrong. You need to make sure they're always on levodopa. You can't stop it acutely. So you can give like a patch of levodopa if you can't give the actual medication itself. I think the treatment choices we've mostly gone over. I think this is a bit of a confusing slide, but yeah, just take a quick look. This one's a little bit better. So these are the 3 main classes of drugs in Parkinson's treatment. So as I mentioned before, levodopa is probably the best for symptoms, and it affects and it makes the biggest improvement in activities of daily living, but it has the most complications. It doesn't have too many adverse effects, so as in like big complications, but it does have some day-to-day complications like the postural hypotension. Dopamine agonists such as bromocriptine, they give you less of an improvement, but they have fewer complications, and you want to use them when you're trying to not use levodopa just yet, when you're trying to stay a bit longer. And MAO-B inhibitors are also something worth learning about. I haven't really covered them that much just yet, but definitely take a look over them. And yeah, that's everything I wanted to talk about. I'll pass you guys on to Grace.
No. Hi, sorry. Can you guys see that?
Not just yet. We can just kind of see the Teams page at the moment.
Oh.
I think it's basically just sharing the page that you're on at the moment.
Hold on, let me just stop sharing again. You see that?
Yeah.
Cool. Okay. So well, where we're going to run over, so I will try and go through it speedily, and of course, if you guys need to go, you can go. So we'll start off with neuropathy. So neuropathy is basically any disease that affects a nerve. And mononeuritis is, for example, in carpal tunnel syndrome, you get the median nerve palsies, radial nerve affected. Then you have the Saturday night palsy, which you might have seen with like a wrist drop and someone falling asleep like on a chair, and they've compressed their armpit. So these are usually caused by forms of trauma. And then there's mononeuritis multiplex, which just means lots of different nerves are affected, and they're usually caused by systemic inflammation. So things like amyloidosis, diabetes, sarcoidosis, cancers, things like that. And then polyneuropathy, general symmetrical degeneration of multiple different nerves. So in terms of mononeuritis, it's a lot of this is just remembering, but I'll go through the stuff that I found slightly more confusing. So with the median nerves, you have the hand of benediction, which if you look towards the left, looks quite similar to a claw hand, which is what happens when the ulnar nerve is damaged. So how I differentiate them is the hand of benediction is when someone tries to make a fist and they can't flex the index and middle finger. That's why it looks like that. And then the claw hand is when they're just relaxing. So all the fingers are sort of extended, but they can't extend the fourth and fifth finger. So the pathology is in two different fingers, but they look similar just as an outcome. In a radial nerve palsy, it's just a wrist drop, so that's quite easy to identify. So that's the Saturday night palsy. And another important thing to remember is for ulnar nerve palsies, if the lesion is more proximal, which means it's close to the elbow, then the claw hand is less pronounced. So that seems more kind of opposite to what you'd expect, but it's basically because there's the opposed. So the palsies only occur because they can't move their hand in the direction of the nerves that are affected. But if so, in this case, it's the extension that's affected. But if it's affected up near the top, then the flexion is also affected. So overall, it's cancelled out both ways. That's why it looks more normal. And the rest, I think it's better to just go through it and remember. The myalgia paresthesia, which is a lateral cutaneous nerve palsy. That's something you'd probably see quite a lot in an SBA because it's just like a burning thigh pain anterolaterally. It's quite easy to identify. And the rest, yeah, go through it. So this is SBA 17. If you guys could just look through it for, I'll give you guys 30 seconds. Okay, does anyone have an idea what this might be? Okay, I'll just go through it because we're running out of time. So this is alcoholic peripheral neuropathy. And so this is, I would say, the key thing to look at is the increased GGT, because then you know the liver is affected. Hepatic failure, of course, it could be a thing, but the clinical picture doesn't show any sort of relation to that. And yeah, there's no signs of diabetes. And Charcot-Marie-Tooth would present earlier with things like foot drop and weakness. And yeah, the E is just GBS, which we'll go through in a moment, but that's, yeah, not the clinical picture either. So this is quite an extensive list, which I think it's something you just need to be aware of. I don't think you need to be able to like say it off the top of your head. But yeah, for example, B12, you know that people can have tingling and numbness in their fingers. And diabetes is quite a main one, and Guillain-Barré syndrome comes up quite often. So those are main things. Of course, sarcoidosis, SLE, Sjogren's. I feel like those are things that UCL quite likes. Celiac disease as well. Yeah. So classifications. So I think you just basically need to know if it's acute or chronic. So if it's acute, then you know if it's something like infection like GBS. And then the modality affected, for example, Charcot-Marie tooth is a lot of motor symptoms rather than sensory. Yeah. So this is also, I don't think it'll come up really in exams. It's just to help you understand it a bit more. So in terms of toxic versus inflammatory, toxic metabolic will be like diabetes, and inflammatory will be things like Guillain-Barré, and things like diseases like that. So the nerve conduction studies, I found these quite confusing at the time, but basically you do an EMG and nerve conduction study together most of the time, and then the EMG records the electrical impulses that your muscles produce. So they just stick a thing in your muscle and then they ask you to contract it, and then they see how much your muscles are able to contract. Whereas the nerve conduction study, they have two I think it's needles as well, along your muscles, and then they give you like an electrical impulse, and then they measure it on the other rod, how long it took for the conduction to occur. So for example, things like demyelination, then the time that it took will be much longer than if there wasn't demyelination. So yeah, this also just shows with axonal neuropathy, you can see the axons are getting shorter, and that's why the furthest places in your body, for example, the feet and toes, will be affected first. And in a demyelination neuropathy, it's a slowing down of the conduction, so anywhere really in the body can be affected. So for example, diabetes can have both of these types, but with the hand and the feet, so there's a glove and stocking presentation, that's a classic type of length-dependent metabolic toxic neuropathy. So yeah, as I said, acute versus chronic, Guillain-Barré syndrome and botulism and Lambert-Eaton syndrome. These are all comes up quite quick. So the Lambert-Eaton syndrome is, I don't know if you guys have gone through it already on PassMed, but it's basically when there's a small cell lung cancer and it affects the calcium voltage channels, and on some patients it means that their muscle contractions are stronger, but over time they become weaker. Yeah. So if someone comes in with neuropathy, you want to make sure that they don't have diabetes, because that's a very common cause, and also vitamin B12, the counts and the HbA1c, and then also check for paraprotein. So it could, because things like MGUS can also cause this, and you can identify a malignancy quickly, because this can be one of the presenting symptoms. So as I said, the EMG and nerve conduction studies will be able to identify any neuropathies. Do an autoimmune screen, so look for celiac, and an infection screen as well. These are sort of things you can list off in an OSCE, but to be honest, I think this is a bit too niche to come up in as an OSCE station. Okay. So this is another SBA. I'll give you guys 30 seconds to look through it. Does anyone want to have a go? Okay, so the answer is B. So it's not A because although it is sort of more acute onset, the symptoms are not quite suggestive of botulism. So you don't have any sort of bulbar symptoms, which is like issues with swallowing, things like that. You don't need a neurosurgical referral as of yet. It's not myasthenia gravis, and you don't need to use steroids in GBS. So these are quite common UCL style questions. You have to know the diagnosis and then decide the treatment. Okay, so Guillain-Barré syndrome. So this is an example of demyelinating polyneuropathy, not the axonal neuropathy. So it affects all parts of the body, not just the sort of the toes and the hands. This happens after a infection with usually Campylobacter jejuni. So you have sort of diarrhea picture, and then a few weeks later, people start getting neuropathy signs. So the classic signs are ascending patterns. So it starts with the feet and the legs, and then it comes up eventually affecting the arms. But this is not always the case. So sometimes just be aware that the classic picture is not, in real life, but SBA wise, that will probably be the case. So you get muscle weakness, which is usually symmetrical. Sensory issues like pins and needles, numbness and pain, and you also have loss of reflexes. So these are quite classic lower motor neuron signs. Just be aware that it can affect the respiratory muscles, so it can be deadly. So, and then you start investigations with the PFTs. So this will assess if the diaphragm has been affected or not. And if it is, then it's more dangerous because you might need to intubate, etc., as it progresses. Of course, the EMG and nerve conduction studies will be really important in this case. And the nerve conduction will be significantly slower than a normal person's. MRI only perform if you have a different pathology in mind. And then the lumbar puncture is diagnostic. So what albuminocytologic dissociation means is basically just you have lots of protein in the lumbar puncture fluid with a normal white cell count. So there's no infection in there, but there's inflammation. Management-wise, if they've started showing signs, then you give them IVIG or plasmapheresis. Yeah, steroids are not used, unlike most of the inflammatory disorders that you might come across. And again, yeah, if the respiratory muscles are affected, you need intubation. Okay. And next we'll move on to the cranial nerves. So CN2 is the visual fields one, which will be tested pretty much every year. We've had it in our year as well. So we'll just go through bitemporal hemianopia because it's the most common one to come across. So what happens here is there is a growth of some sort that presses on the optic chiasm, and you just remember whichever way it's pressing, the sign will show up in the opposite way. So if the upper visual fields are affected, the most likely cause will be a pituitary tumor, pituitary adenoma that grows from below the optic chiasm. And if the lower temporal fields are affected, then it's more likely like a craniopharyngioma that grows from above the chiasm. So this is another SBA. I will give 30 seconds and then we'll go through it. Okay, does anyone want to, sorry for that bit of a jump scare. Does anyone want to have a go? Okay, so the answer is diabetes, and we'll go through why. So the main thing here is you can probably see that it's a CN3 issue because the eye is down and out. There's proptosis, which is the drooping of the eyelid. And then the main key differential here is identifying that the pupil size is staying the same. So the pupil has not dilated. You call that pupil sparing, and this only happens if it's a medical third nerve palsy. So what does that mean? Let me go through here. So the top picture is a not pupil sparing picture because you can see the patient's right eye. So the left eye from here is dilated, whereas the bottom one, the pupil is spared. So the bottom one is more likely diabetes, and top one is more likely things like aneurysm. So we call that a surgical nerve palsy. And the reason why this occurs is along the fibers of the cranial nerve 3 is running parasympathetic nerve fibers just on top of it or just around it, around the main nerves. So if something's compressing on the CN3 nerve, then it also presses on the parasympathetic nerve. And as you probably know, the parasympathetic nerve allows the pupil to constrict. So if it presses on those nerves, then the pupil can't constrict anymore, so you get a pupil dilation. So this usually occurs because of things like aneurysms or herniations or tumor. So if a young patient comes in, for example, with a more of a trauma picture, then it will most likely be a surgical nerve palsy. And then on the other hand, if it's like an elderly patient with hypertension or diabetes, then that's more likely to be inflammatory. So it doesn't affect the outside of the nerve where the parasympathetic nerve runs, and that will spare the pupils. And also it'll be painless, whereas the surgical nerve palsy can be painful. So CN6 palsy, just remember that this is the longest nerve of the whole cranial nerves. So when the intracranial pressure increases, it's one of the first nerves to be affected. And I don't know if you guys have heard of SO4 LR6, but that's how I remember the which muscles are affected by which nerve. So the lateral rectus is affected by CN6, which means that you can't abduct the eye anymore, so that the eye will constantly be looking towards the nose, towards the middle. So as we said, CN3 nerve palsy will have ptosis and proptosis, fixed pupil dilation, and eye looking down and out. So with CN4, people will present with double vision and a tilted head away from the side of the affected eye. So I found this quite confusing to understand. But basically, what happens is the superior oblique muscle, what it does is it tries to bring the eye down and in. So if that doesn't work, then the eye is looking up. And then to balance that, you tilt the head towards the other way, because if you do that, then naturally the eye is supposed to look this kind of I don't know if this is making sense, but naturally the eye is supposed to be looking that direction. So then it balances it out and the people don't see the double vision anymore. But yeah, basically just remember the head will tilt the other way of which side the palsy is. And then we'll go through Bell's phenomenon as well in more detail. So SBA 20, if I just give you 30 seconds. Does anyone want to have a go?
Is this one C?
Yep, great. That's really good. Do you want to talk through why?
Yeah, I think there's a differential varicella zoster virus and Ramsay-Hunt syndrome. So you want to rule that one out first.
Yeah, perfect. That's exactly why. So, yeah. Yeah, CT head is not usually indicated. Tenderness of oropenicillin, yeah, so this is probably what some people might want to go for, but you just need to rule out Ramsay-Hunt first, as he said. And acyclovir is not given unless you've found out it is Ramsay-Hunt. Okay. So, also, yeah, because it's the forehead is forehead sparing, so it's sorry, this wasn't forehead sparing, was it? Yeah, okay. So then it's not a stroke. So this is also slightly sort of not what you expect, but the forehead is spared if it is a stroke. And this is because if you look at the diagram on the right, so if in the stroke, if the lesion is coming from a more cortical area, then the innervation to the forehead from the other side of the brain will be able to move the forehead. Whereas if the lesion is more in the lower motor neuron, then both of these innervations will be affected, so you can't move the forehead either. So Bell's palsy is a classic facial nerve palsy, which is diagnosis of exclusion. So as you said very correctly, you need to first rule out Ramsay-Hunt syndrome, look inside the ear. So this is basically shingles of the facial nerves. So you'll be able to see the classic picture in the ear. So and then you'd also have Lyme disease as a possibility, but I think this is quite niche. It doesn't really come up. And then I don't know if this is not relevant. Yeah, so if it was a stroke, then there's also the potential of it being hemorrhagic or ischemic, or it being a tumor, but tumor would be more of a slow growing picture. And multiple sclerosis as well. I don't think the rest are that relevant, other than I don't actually know how to say this word, but it's basically a tumor inside the ear, So that can sometimes press onto the facial nerve. So Bell's palsy, once the other things have been ruled out, then you can diagnose it as Bell's palsy. So they don't really know why it occurs. The pathophysiology isn't clear, but it's a facial nerve palsy. So if you ask a patient to close their eyes slowly, then you'll see the eyes rolling back. And what you should do is basically give them steroids for 10 days. And then if they're not able to close their eyes and the eyes can dry out, then you can give them some either eye drops or taping for them to close the eyes. And you don't give them acyclovir, as some guidelines might suggest, but you only give acyclovir if you think it's Ramsay-Hunt syndrome. Okay, so hope that makes sense. Sorry, I've really rushed through the last slides because we're running over. If you guys could fill out the feedback form, that would be really helpful. And if you have any questions as well, please ask. And thank you so much for staying.